Good evening, all. After this excellent talk by Deepta regarding that pragmatic use of C-peptide in differentiating different type of diabetes, what we see in our day-to-day practice, to differentiate the gray to white and black, and to help us to determine the treatment of different diabetic patient. Now we are all excited to listen from one of the senior teacher of our country, Professor Rakesh Sahay, sir. Can we have the slide, please? Sir is a senior endocrinologist, professor and head in Department of Endocrinology, Osmania Medical College and Hospital, and also attached to Shahay's Endocrine and Diabetes Center. Sir has been the president-elect in Endocrine Society of India and had chaired the many important position in different academic societies all over the India and world. Sir has got the fellowship of American College of Endocrinology in 2009 and RSSDI for 2015. Indian College of Physicians in 2006, Indian Academy of Clinical Medicine 2008, and Sir has numerous publication and citation in various peer-reviewed international journals. So, without wasting any further time, I will request Professor Sahay to kindly start. Thank you, sir.
Thank you. I'll share my screen. I would like to thank the chairpersons for the kind words of introduction, and also would like to thank the organizers, the Bengal Diabetes Foundation, for inviting me to be part of this this important conference, the Bengal Diabetes Conference. And I've been here from yesterday, and I found the talks to be the topics to be extremely useful and clinically relevant. And I congratulate Dr. Amitabh for the excellent presentation, excellent organization of this conference. So this topic that I've been given is in this session is supported by Roche. So what I would be discussing is about the fallacy of using HbA1c alone in managing diabetes, how it should be complemented with SMBG, and how this works very well is what I'll be discussing in the next 18 minutes or so. So, so if we look at HbA1c, HbA1c has been the gold standard for the management of type 2 diabetes for last 30 years. I would say from the time the results of the UK-PDS and the DCCT came out in early 90s, they have actually made a big impact in terms of our understanding about the role of glycemic control in managing patients with diabetes and how we could reduce the risk of complications. The UK-PDS showed that every 1% reduction in HbA1c results in a statistically significant reduction of 37% in the microvascular complications and 14% in myocardial infarction. So that, and again, the DCCT again showed a similar result that for on the average, every 1% reduction in HbA1c brings down the risk of microvascular disease by about 30%. So that actually made HbA1c the gold standard. And then since then, we have been using HbA1c as a gold standard for monitoring glycemic control. And we have in fact sort of used whatever assays we used are traced back to the DCCT assays to give us a information that what we are doing is on the right, that we are on the right track. So if you look at HbA1c, it has several advantages. It is predictive of vascular complications. There's a huge amount of data available from I would say millions of studies across the globe which have looked at HbA1c and the correlation with microvascular complications and the macrovascular disease also, and they've shown that there is a very good correlation, and that becomes a gold. I mean, that has remained as a standard test for measuring glycemic control. It makes very good. It gives you very good help in terms of making management decisions regarding therapy that has to be used, the way we have to start insulin, when we have to start insulin, when we have to use monotherapy, when combination therapy is going to help. So in all these management decisions, it is a very useful tool, and it is also easy to measure. It is relatively cheap. It is costly in doing the blood glucose measurement, but as when you compare it with many other tests that are required, it is relatively cheap, and it is because of its robustness in terms of the use in the last 30 years. it has become a very good sort of test, which has quite a good robustness in terms of understanding the risk of complications. Although we still have problems in terms of standardization of HbA1c across our country, but I would say that over the last 1 decade or so, we have achieved a lot, and we have moved quite significantly forward. Now, HbA1c has several limitations. I'm not discussing about the limitations in terms of the standardization and the quality of HbA1c assays available. I'm speaking of, when HbA1c, we have got a good, reasonably good, reliable HbA1c assay. Even then we have problems with HbA1c. So that is the point that I'm trying to make here, is that when you're using quite a good HbA1c, which is from a reliable source, I mean, using a good standard method of doing HbA1c like the HPLC or the affinity chromatography, what we see is that it still has problems. One is that it provides only an approximate measure of the glycemia. You do not know the glycemic status at that point of time. So that becomes a major problem in terms of deciding what type of therapy is to be used, what immediately has to be making immediate therapy decisions or making immediate changes in the medications. You require, in addition to HbA1c, you require more information that is probably provided by doing SMBG. And it is unable to address the glycemic variability or also the risk for, or also it is unable to detect hypoglycemia when it occurs. So that is something which is a major limitation of HbA1c, that it provides an average level of the last 3 months. So it does not provide us information of what is happening around that mean, because there may be a lot of fluctuation around that mean, but that is not seen by the HbA1c alone. So therefore we need more sort of reliable tools to understand that. It is unreliable in presence of renal failure, when there is hemoglobin abnormalities, the hemoglobin S, sickle hemoglobin, or thalassemias, and all those conditions also, there may be errors in measuring HbA1c. Now, so that's why it's important to monitor blood glucose levels, because they show us the changes during the day. And these glycemic fluctuations, we also know now that we have more reliable ways of measuring the glycemic fluctuation, we also know that whenever there's a rise in glucose level, that is dangerous. Even when there's a rapid fall, then there is an oxidative change induced, and that oxidative change can lead to damage to tissues. So this is how, you could have fluctuations across the mean and around the mean, and that could not be picked up by HbA1c, and that could have serious implications. Now, HbA1c is what we see is that there are limitations. These limitations which we are speaking about is like, if you're looking at it does not indicate the glycemic variability. The magnitude of excursions that a patient may experience during the day are not shown by that. And therefore, this is one important parameter that is not assessed by HbA1c, and that has come out once we have got better tools for monitoring glycemic variability, like the continuous glucose monitoring systems which are available today. Now, to illustrate this very clearly, I would show you I would like you to look at these two patients on the right side. There's a subject 1 who's got both these subjects have a HbA1c of 8%. That is, their average blood glucose levels have been 8% in the last 3 months. And if you look at the subject 1, he has a different pattern as compared to subject 2. And as you can see, subject 1 has very high glycemic variability, has got almost 8 to 10 episodes of, in that small, in that window which we're seeing of, say, maybe a couple of days, we are seeing that there are significant glycemic excursions, there's significant peaks. In this picture itself, we can see about 8 peaks. And then there are significant periods of time when he has developed hypoglycemia, almost going down to less than 50, which is quite severe hypoglycemia, developing on several occasions. And if you look at subject 2, on the other hand, he has the same HbA1c level of 8%, but with much less glycemic variability, showing that his glucose levels are almost around that mean of about 160 or 150, 160. So this shows that there could be a error in picking up the glycemic variability. We may not pick up the glycemic variability. And apart from this major limitation about not being able to identify glycemic variability, we have got other problems, like you may have falsely low HbA1cs regardless of the assay method. I mean, that is, if you're using a good assay method, in spite of that, you may have falsely low HbA1c when there is a shortening of the lifespan of the HbA1c, as happens of the RBC, as happens with acute blood loss or hemolytic anemias, or also with the use of some medications which are used for treating patients with HIV infections. Then you could have falsely high HbA1c levels in patients who have got iron deficiency anemia, who have got hypertriglyceridemia, hyperbilirubinemia, uremia, and those using high doses of acetyl salicylic acid. And similarly, the assay method can have also an effect on the this thing on the measurement of HbA1c, as can happen with various hemoglobinopathies and those which increase the RBC turnover. And use of blood transfusions can also give rise to problems in the HbA1c results. So apart from these, so how do we overcome this? So the best way to overcome this is to complement the HbA1c with the SMBG, because HbA1c provides very valuable information. If you complement it with SMBG, that makes it very good, because SMBG provides a real-time measure of the blood glucose levels. It provides patients with instant feedback of what is happening based on their, the effect of various foods, the effect of various exercises, whenever there's a stress or any type of medication change that is happening. Immediate feedback is provided, and this can help clinicians and also patients in fine-tuning their schedules and also the medication use. So SMBG can provide information about hypoglycemic episodes. It can help in identifying postprandial peaks in blood glucose levels, which can happen with different meals, and this can actually aid very much of deciding therapy. And if you look at the benefits, so this is one interesting study which I would highlight here. In this study, what they looked at is that they looked at the risk of complications. If you look at the risk of complications, it's about you can see the list of, the risk of complications, cardiovascular complications is about 6.8%. Is there any problem? Am I audible? There's some disturbance. Okay, so what I was saying is that when you look at the risk of complications, cardiovascular complications, 6.8% without, in patients not doing any SMBG. If you look at patients doing at least one SMBG per day, they showed that there was a 10% reduction in the risk of cardiovascular complications. Similarly, food complications, eye complications, renal complications, whatever you look at, there's at least a 10% reduction with SMBG done even once a day. So that is the great benefit of doing SMBG, advising patients to do a SMBG at least once a day. And you could see the cost difference that is provided in the same analysis. What you see is that if you look at the costs over 10 years for managing these complications, and if you are expecting a 10% reduction in this complications, if you look at the cost, that comes down so much. And if you factor in the cost of doing the tests, also with the cost of the meter and the cost of the strips over the 10 years, doing it once a day or 7 times in a week, this is the difference in cost. Almost a saving of 1 lakh rupees over a 10-year period. You have saved so much of money after factoring in all the costs of doing the SMBG. So clearly there's a benefit of doing SMBG, and this is shown not only from this one study which has tried to monetize the benefits, but also if you look at various controlled clinical trials, a meta-analysis of several trials, observational studies, and 10 clinical practice guidelines and all that. If you look at all this, you find that there is a use of SMBG had a positive impact in terms of achieving glycemic control and providing definite therapeutic benefit in terms of deciding the therapeutic changes that are required. Now, let me just show you some of the studies which have looked at doing SMBG and seeing the benefit of SMBG. This is the Y-Weight program, which is quite popularly known by everybody. This is a real-world clinical practice data on looking at how intensified SMBG has helped in.
Sorry to interrupt you, sir.
In terms of achieving favorable weight loss.
The slides are not moving.
Slides are not moving?
Problem, right, sir. We are just seeing on. No, sir. I think some problem is there. Kindly check.
Which
Rakesh,
one?
I think we are seeing that earlier slide.
Rakesh, Manoj, here the slides are blank. You want to stop and start sharing again?
Yeah,
maybe
okay, I'll stop sharing and start again. Sorry for that. Is it seen now?
Yeah. Yes.
It's fine, sir, now. It's
Yeah.
fine, sir.
So what I was saying is that if you look at the YWAID program, and if you look at patients who were on different tertiles of SMBG measurement. So if you had the lowest tertile, which on the left, which looked at patients doing it about 2.3 times per day, versus the one in this group of patients doing it about 5 times in a day. So if you look at the difference between these, there was a significant difference in terms of the achievement of weight goals and reduction in their in their BMI and the A1C control that they achieved with that. So this shows that the graded SMBG, doing it more frequently, even doing it once a day, we saw in the previous study that it made a significant economical benefit. And when you do it more frequently, you have that additional benefit. And this is a prospective 18-month trial which had shown that by doing SMBG, you could identify the postprandial peaks, use appropriate therapy to reduce postprandial hyperglycemia, and bring about a change in the carotid intima media thickness, because that's clearly affected by the SMBG, the postprandial glucose levels. So it's a very important tool which helps both in patients with type 1 diabetes, type 2 diabetes. It helps in optimizing the insulin treatment in patients who are treated with insulin. It provides for help in also in adjusting the therapies, and also helping in patients in understanding their lifestyle changes. And different studies have shown this benefit, and you could achieve near normal glycemic control without increasing the risk of hypoglycemia with the appropriate use of SMBG. So even in patients who have got very high HbA1c levels, you could achieve a better control with the use of structured SMBG. You could get the benefit in terms of optimizing the physical activity goals. Nutritional goals can be optimized by using SMBG and providing a feedback, because it provides a feedback to the patients in terms of this information. So to take full advantage of SMBG, we should establish a glucose profile, collect data at appropriate times during the day, recognize the readings that are outside the target range, and take actions to improve the glycemic control. So this is very important, because if the patient is doing this, then only the benefit of SMBG is seen. Otherwise, if a patient is just randomly doing the SMBG and not taking any action on that, not taking appropriate action, then probably the benefit is not seen. So if you have to instruct your patients to do the SMBG, you need to tell them to record these readings, establish this glucose profile, and then take corrective actions so as to achieve the HbA1c and achieve the better targets that we're looking at. And also pattern recognition is very important. So that's a systematic approach to recognizing the glycemic patterns within the SMBG data, and then taking appropriate action based on these results. So you need to educate patients on establishing both pre-meal and post-meal glucose targets, gather these data, and also look at their carbohydrate intake, their insulin doses, their activity schedule, and the physical and emotional stress that they're going through. And this will, when you analyze this information, that will help you in making appropriate decisions in terms of providing better control. So if you look at the recent AD recommendations on SMBG, they've highlighted the importance of combining the results of SMBG along with A1C and CGM in appropriate patients where it's required. And they've highlighted the fact that major clinical trials of insulin-treated patients have included SMBG as a part of the multifactorial interventions to demonstrate the benefits of intensive glycemic control on reduction of diabetic complications. They have also highlighted the fact that SMBG would help in guiding medical nutrition therapy and physical activity, preventing hypoglycemia and adjusting the medication. So SMBG has a significant role in terms of providing all these benefits when it's complemented well with the HbA1c levels. Even the RSSDI and Endocrine Society of India in their guidelines have highlighted the importance of SMBG as a very important tool in monitoring glycemic control. They have highlighted that HbA1c complements with HbA1c, and they have also highlighted the fact that it can be used for hypoglycemia prevention, recognition and treatment of hypoglycemia, and in patients who are treated with insulin. And they've recommended at least once a weekly monitoring of SMBG. And they've also mentioned that the ideal would be to do 7 times per day, but at least once a day in insulin treated patients has been advised in our own ESI Endocrine Society RSDA guideline. So I would to To provide all these benefits, Roche has also actually come out with an integrated personalized diabetes management platform, which is a digitally supported and structured concept with the to provide this structured SMBG, and where the data which is collected is integrated into the management software, and it helps and the physician in collaborating with the patient in coming up with important therapeutic decisions. So I would like to end by saying that SMBG is an essential component of the modern diabetes management. It complements very well with HbA1c testing, as it can differentiate the fasting, preprandial and postprandial hyperglycemia levels, detect the glycemic excursions, recognize and contribute in monitoring the resolution of hypoglycemia, and provides immediate benefit, immediate feedback to the patients about the effects of blood of their food choices, the activity that they're doing, and the medications which they're using for achieving the glycemic control. SMBG facilitates patients and healthcare providers to adjust their therapeutic regimes in response to blood glucose values, and regulate the dietary intake, physical activity, and insulin doses to provide improved glycemic control on a regular basis. Embedding these SMBG values into a digital platform like the IPDM have proven to provide a benefit to insulin treated patients with type 2 diabetes and their physicians. So I would like to conclude by once again saying that HbA1c remains the gold standard for managing diabetes, but it has to be complemented with SMBG where required, and currently with CGM where indicated in a few patients where it is going to be very useful in terms of making these decisions in their day-to-day management of diabetes. Thank you all for the patient hearing.
Thank you, sir. Thank you for your excellent talk regarding not only the various pragmatic measures that we have in our armamentarium to not only diagnose and for the monitoring of the day-to-day diabetic control for the patient, and the role of SMBG in day-to-day practice in a country like India, where the more like advanced or the newer techniques like TIR, which is not practically affordable for all the patient. We cannot do that in all the patient. So with this excellent talk, I will ask my co-chair, request him to kindly introduce the third speaker for the session, and all the question answer we'll take after the third talk. Thank
you. Good evening. So for the third talk, we have Dr. Manoj Chawla. Can I have his introductory slide? I cannot see it.